morning.
That's fine.
Fantastic. And to my immediate right, I've got Evans Nyambega, a stroke survivor, as well as the chairperson, Stroke Association of Kenya. Karibu sana, Evans.
Good morning.
Good morning to you too.
Morning.
Karibu tena. You've been here before.
That's
and
right.
it's a pleasure to have you. I'd like to begin with you, Daktari.
Yes, please.
When people hear of this term, stroke, it's subject to various interpretations. However, what is the medical interpretation of a stroke?
Many thanks, Sam, for the introduction and for the welcome to the studio today.
You're welcome.
Stroke, to start from basics, is a disease of the brain. It happens when a section of the brain suddenly stops functioning. And this lack of function comes because of the blood supply to the brain. So you may have a blood clot suddenly blocking supply to one part of the brain, or a rupture of a blood vessel that was supplying blood to a particular part of the brain. So when this happens, that section of the brain does not get an adequate supply of blood. And therefore it stops functioning and ceases to thrive. The part becomes largely dead part of the brain.
Right.
So when that happens, because the brain controls every aspect of your being, the brain controls your movements, the brain controls your speech, the brain controls your personality, your emotions, your memories are all stored in the brain. Who you are is all in your brain.
Yes.
So when that happens, a part of the brain stops working and the function which is held in that part of the brain stops.
Yep.
So if it's the function that controls one side of your body, for example, then you get paralysis on one side of your body. If it's the function that controls speech, then you lose your speech. If it's the function that controls balance, then you lose your balance. So it can happen and affect anything because the brain controls everything that you are. But the commonest manifestations will be largely weakness of one side and changes in speech.
Changes in speech.
As well as lack of disturbance in balance and coordination.
And coordination. So it's more or less a condition that has triggers, or it is triggered by something.
Absolutely. There are things that can predispose you to the development of a stroke. You see, in the normal situation, your blood vessels are intact and they're supplying blood to your brain, and there's nothing that should disturb that kind of balance. But occasionally you get things that disturb the functioning of your blood vessels. So really you can say stroke is a disease of blood vessels. So it's a disease of blood vessels that supply the brain. So conditions that cause damage to your blood vessels will lead to a stroke. And some of these conditions are things like high blood pressure. If your blood pressure is very high, it causes a lot of stress on your blood vessels. And the blood vessels that take blood to the brain will be affected, and that can happen. If your blood sugar is high, if you are diabetic, that will cause damage to your blood vessels. If you have high cholesterol, that will cause damage to your blood vessels. If you are a smoker, smoking will cause damage to your blood vessels. Heavy usage of alcohol will cause damage to your blood vessels. So largely all these factors which damage the blood vessels that take blood to the brain will eventually could lead to the development of a stroke.
Heavy use of alcohol. Okay. We'll come to that in a bit. I've got a question of how heavy is heavy. Because heavy is relative, isn't it?
Yes.
But before I come to you, Oscar, let me come to you, Evans. Kindly tell us a bit about yourself.
As I've said before, I'm a stroke survivor. Now 8 years. This I credit 8 years. And I suffered from this disease simply because I didn't know about it. I had very little knowledge about it, and when it came, I mean, there were no major warnings. Although I can remember bit by bit. I mean, some symptoms which it was setting to me, but I was not, you know, in a position to tell exactly what it is. One, there was sudden confusion. Sometimes I could go to maybe to my house to collect something, then all of a sudden I forget again what I was going to do. You know, this kind of thing. So, I later on discovered that there are many more, like coordination. I was not able to. Sometimes I could say I want to do ABCD, and all of a sudden I forget. So really, these are the intricacies of this disease. Yes.
There's something you've mentioned about memory.
Yes, memory. Actually, it has a very big impact on memory.
On memory.
Yeah.
I'll cross to you, Dr. on that note of memory. Oscar, coming to you. As an occupational therapist, when you're handling a stroke survivor or a patient, what do you consider?
Okay, the first stage of stroke, you just look at the manifestation of stroke, of which, as you understand, as occupational therapists, we fall under rehabilitation. Of which under rehabilitation, we've got an occupational therapist, a physiotherapist, and a speech therapist. Of which when you see people with stroke, they've got challenges with speech, as you have heard from the doctor. There's issues with paralysis. Somebody loses the function of the hand, mobility issue, which means that person is no longer able to walk. So the first time you have to assess to ensure that you're able to identify all the issues that a stroke patient has, of which largely they are very dependent at that stage, especially at the acute stage. Acute stage is whereby you find a patient is not able to do anything, is bedridden. So as an occupational therapist, at the first stage you must ensure that you prevent issues like this, issues we call bed sores. Because this person is largely sleeping, is immobile. So we ensure that we prevent skin breaks. There's issues to do with what we call splinting, whereby you find these people, they have their limbs, largely they may tend to have some weakness. Especially we've got something we call wrist drop. So this wrist drop, we make a splint, whereby we try to position this hand to a functional position. Yeah, so that when this person recovers, at least we have that functional capacity. Yeah. Other issues is we try also to ensure that all the family members try to understand that this person with stroke need to be supported, because largely most of people with stroke, there is a tendency of family members leaving the person in that stage because they see this person, it's a burden or is a...
Others don't understand.
Yeah, they don't understand it.
Yeah,
and these people, they largely need support at that stage for them also to be motivated during recovery.
During recovery.
Yeah.
Dr. Harry, coming to you, let me begin with the issue of memory. When you realize that you're beginning to forget things slowly, or you're struggling to remember things, is that a red flag? Should you just panic and say, oh my God, stroke is on the way? How should you treat memory loss?
Now, memory is quite a complicated kind of function of the brain. It's affected by many different factors. And there are so many different conditions which affect your memory. But the commonest that you get today is not even a very serious disease. It's basically stress and the lack of enough sleep and such things. And you find a young person such as yourself, you cannot remember things in the morning because basically your brain is not rested, is not in a healthy state to be able to keep memory intact. So memory, if you find you're forgetting, don't panic, don't think it's a stroke. Another thing which may happen is there are diseases of, say for example, things like dementias. Now, dementias are diseases of long-term memory loss and change in personality and that kind of thing. So this usually happens in older people. So some people, as they get older, they begin to forget. It starts slowly by slowly. They place something here and they don't know where they have placed it. They start forgetting people's names. And this worsens. to a point where they are not able to carry out any of their usual functions and they become dependent. So that's another condition altogether, which is not largely related to stroke. Now, for stroke, because as we said earlier, the brain controls every aspect of your being, including memory. And there are regions within the brain that are key for the processing or for the management of your memory. Just like you have a memory card that you put in your phone.
Yeah.
So there are regions of the brain that are very useful for the management of memory. So if a stroke happens to affect this part of the brain that manages memory, then you find that your memory suddenly disappears or changes and you cannot recall things that you could do before. That's right. So that's one of the things. So it's not, the stroke, remember, comes in all of a sudden. So you are fine this minute, and the next minute you find that things have changed for you. Yeah. So if a person happens to find that their memory is deteriorating slowly by slowly, and over time, over many months, then that is not a stroke. That could be a different condition altogether, which will need assessment, and you'll know what it is based on their age, how this memory loss is presenting, other factors which are there. Yes, absolutely.
It's a very good point to note. However, he said, if I relate with what Evan said earlier, when it comes to stroke, I think there are things anyone should look out for. You know, signs that they should be aware of, that all is not well. Because he rightfully said that he was going through things that he could not understand, and he did not know where it was headed. So maybe for the purposes of our viewers this morning, what are those things that we can look out for, that should we identify them, then we should seek medical attention?
Now, stroke by definition, and I think that's why it was called stroke, because it strikes you. It strikes you suddenly. So it's without warning. So most of the time it's a silent disease. Because you are fine and you think you are doing well. Most people say I was fine, I was in the gym, I was walking, I was eating, and then all of a sudden I found that I collapsed or I was weak or something happened. So there are not too many warning signs that you will figure out before the stroke actually happens. But there are a few, because some strokes present with little tiny strokes or transient attacks before the actual stroke comes. So these things medically are called TIAs. Now, TIAs is when you get partial blockage of a vessel, which opens up before the actual stroke has happened. So you may experience, and maybe that's what Mr. Nyambega was having, Dr. Nyambega was having, because when you get that transient blockage, you can have a brief period of confusion, a brief period of weakness of your hand, a brief period of loss of speech, just lasting from seconds to minutes, maybe an hour or so. That can happen. So that's a very good warning sign that a stroke is coming. So if a person suddenly you are fine, then you find that your speech is slurred, you cannot express yourself, people cannot understand what you are saying, or your hand is weak, or your face droops to one side, and then that improves after a few minutes or after 1 hour, then you could be experiencing let's call it a pre-stroke, or a warning that a stroke is coming. And if you get appropriate treatment at this point, you might be able to prevent a more permanent stroke from developing later on. So that is one warning sign which one might talk about. The most important thing, if one wants to avoid a stroke from attacking them, is to manage those factors we talked about. The risk factors. So every person needs to be screened for high blood pressure, for diabetes, for high cholesterol.
How often?
Well, most people talk about annual or yearly checkups.
Yes.
But also this depends so much on the patient's age. A young person who is healthy, has a healthy lifestyle, doesn't eat a lot of junk food, is not overweight and so on, may not need very regular screening. But an older person who is 60 years old, has hypertension, has diabetes, has everything, will need closer follow-up. So it's best to do this in coordination with your doctor, who is going to advise you that based on your overall state of health, you can relax. You are not at risk. You are young, you are 20-something, you don't smoke, you don't take alcohol, you live a healthy lifestyle. Therefore, you can relax. But on the other hand, your doctor might tell you, you see, your health bill doesn't look too good. Your balance looks poor. Therefore, you need regular screening for the development of these conditions.
Bwana Nyambega, I'm with you in terms of your life before. If I remember your story correctly, the last time you were here.
That's right.
You were an active person.
Very active.
full of life,
Yes.
a lot to look forward to.
Just like you.
Just like me.
Yes.
Just like me and many others
And
on the
many
set
others.
this morning.
Yes.
But then you went through this condition. To what extent did it affect the quality of your life?
In fact, so much that as an active person, and then all of a sudden, from grass to
From grace to grass.
from grass, whatever. Now, when it happens like this, you just start now wondering, really, is this me or another one? So not unless you have come to yourself and accepted that, yeah, it's me, and then you move forward. And very few people can do that. I was lucky because I'm endowed. What about those who are not endowed? So it is actually a big problem, because like you want to get well, the first thing is to accept. You accept that now actually it has happened, and it has happened because of this, because you now need to be told by like a neurologist, now you have stroke. You have a condition called stroke, and this condition requires ABCD. Then it's only when now you can now start healing. You see?
Slowly.
Yeah, slowly. And like I am now, this is my 8th year. Still my hand is not fully functional, but now I'm able to, to do things here and there. I am now able to organize a little while. I can do my things. I can take care of my family, which I was not doing before. Yes, so really, the idea of stroke is a journey. It's a journey that is actually very difficult to go by.
One of the things that comes to my mind right now is that, and I don't mean to be chauvinistic or anything, but for a man this can hit really bad. Because one, we are not used to being too dependent.
Yeah.
And we like being in charge as men.
That's right.
And then you suffer from this condition, all that is taken away. You have to depend on
Yeah,
people.
the roles change.
The roles change. You have to depend on your family.
That's right.
In fact, now you're looking up to them. You're no longer as in charge as you used to be.
Yes.
How did you handle that?
Actually, Sami, I was lucky because my family welcomed this idea very well, and then they actualized the idea. Then, it is because they understood that now our father, like my wife, my husband, is no longer now doing things he was doing. But now we want to assist him to come up. And actually they assisted me so much. That's why I'm able to be here today.
To be here today.
Yes.
Coming to you, Oscar. Family, relatives. Once a patient is discharged from hospital, and now it is up to the next of kin to take care of them, what should they consider as they try and, make life manageable for this patient? What should they do?
Okay, one thing is we have to sit down with them. We draw a plan. We ensure that when this patient goes back home, how will the family take up this patient?
That's right.
One thing is they must understand this condition very well, the challenges of this condition, so that they will be able to support this patient in whole areas. Because this patient, they've got a lot of challenges, of which it's a burden to the family.
Yeah.
And as occupational therapists, we look at the level of independency. So as we go on, we are trying to look up that once this patient recovers, is able to do things independently. Of which, as when you say occupation, we say everything that you do in daily activities. For example, for you, you wake up in the morning, you took a bath, you brushed your teeth, you took your breakfast, which we call it occupation. So for people with stroke, we must ensure that they start being independent in these activities of daily living, which we call it skills retraining or retraining in these occupations. That's right. Of which that is our core value as occupational therapists.
As occupational therapists.
Yeah.
Good points to consider there. Daktari, earlier on you said that we should look out for some telltale signs. Things could not be well. In the event you seek medical attention in time, is stroke reversible? Are you able to avoid it, prevent it?
Now, that's a very important point that you raise, because for a long time it was not reversible. But in the last few years to decades, treatments have come up now which try to reverse the stroke. And they are really expensive treatments, and they require a lot of organization and management. So many countries have not yet taken this up very well yet. But in countries in Europe and other places, if you get a stroke and you present to hospital within a few minutes, you can be given treatment which can try to dissolve the clot. That's when you have the type of stroke which is caused by a blood clot. You can have treatment which tries to dissolve the clot. Recently, there's even advances where you have treatment where you can try to put a little wire through the blood vessels and get hold of the clot and pull it out. And once you pull it out, blood flow is restored again to the brain. So if a person presents to hospital very early, in centers where these treatments are available, because they require a lot of training and they are very, very expensive. So in Kenya, they're not available in many places, but they are available in a few of the major hospitals in this country. So if a person presents very early, then that treatment could be given. And that's why internationally, when you're trying to sensitize people about stroke, you use an acronym or something called FAST. So you tell everyone to remember FAST. So when you see someone with F, the face is drooping on one side. A, one of the arms is weak. S, speech is slurred and they're not able to understand or express themselves very well. T, time is of the essence. You've got to move quickly and take them to hospital. So if everyone realizes or knows about FAST, then hopefully people who are developing strokes will be able to reach hospital within a very short time. And our hospitals now, because at present there's probably not much point in rolling out many of these acute or early treatments in this country, because many people reach hospital after a day or two. And a person begins to get issues and they think, oh, I'm just tired, or maybe it's just stress. And therefore, if I go to sleep in the morning, I will wake up and I'll be fine. And when they only come to hospital after they find that this issue has persisted. Now that needs to change so that a person who suspects they're having a stroke tries to rush to hospital as quickly as possible. So the people around, the relatives and friends need to understand or know about FAST. So that if you find your colleague or your parent or someone is developing facial drooping on one side, arm weakness, speech is not clear or it's slurred, then time is of the essence.
Time is of the essence. In terms of demographics, who is more prone to a stroke? One, male or female? Number two, in terms of age, a person like myself, what are my chances of having a stroke vis-a-vis someone who's 50, 60 years of age?
Stroke largely is a disease of advancing age. It can happen even in very young people, even in children. Strokes happen for various reasons, even in children. But largely, it's a disease of advancing age. So the older you are, the more likely you are to have a stroke. Just age alone is a risk factor. Even if you don't have hypertension or diabetes or anything else, just the fact of that you are getting older, is a risk factor alone for stroke. And the older you get, the higher the chances of stroke developing. Gender. Men are more likely to get strokes compared to women. Women, especially the younger women, until they reach the menopause, they are slightly protected against strokes by their hormones and that kind of thing. So, and after menopause, women also, the risk for stroke goes
Higher.
up again. And therefore, younger women from the age of 50 and below probably are not at such a high risk of stroke as men are. So those are the demographics in terms of gender and age. In terms of racial characteristics, a lot of people have pointed out, but these are studies done in elsewhere, that African origin people or black people are higher, they develop strokes more than other races. So that's another issue in the demographics, which is talked about in other countries which have got, where the Africans are a minority. But here, the majority of the population is African. So that doesn't really become out as a strong factor because we are all largely the same people. Family history also is another thing. If you have had a family history of a stroke, your father had, your uncle, your grandfather, your mother, then you are also at a higher risk of developing stroke. Because some of these factors are inherited. And remember, the stronger the family history. If all your parents and grandparents had strokes, then you're also at risk of getting stroke. If it's only one person who had, you're also at risk, but at slightly lower risk than the person who has got a very strong family history. And therefore, it doesn't mean that if you have a family history, you just give up and say, now everyone got a stroke, therefore it's going to happen. No, it means you have to work on your risk factors. Try to see, is it hypertension that is there, what is happening? And maybe you can also take medicines like aspirin every day to prevent a stroke from coming, because it's also possible to do that. So one needs to always identify their risk factors. Because as I say, and maybe this is something I'm going to emphasize later, prevention of stroke is much, much more important than waiting to treat it once the stroke has occurred. Because a stroke, remember, has got a wide variety of manifestations. A very large stroke can suddenly kill you. So you get a stroke and suddenly you drop down, and it's one of the causes of sudden death. You just suddenly get it and you're gone. Or a very minor stroke may even go unnoticed. So it's a whole spectrum from death to something which happens and you just feel something, then it's over within a few minutes. So it's a whole spectrum of activity. But once it has happened and the stroke has matured and it's there, reversing it is difficult. That's why occupational therapists have to be there, because it takes many months and years. Our colleague has been battling or handling his rehabilitation for the last 8 years.
8 years, yeah.
So it's a difficult and expensive business trying to treat a stroke once it has happened. But preventing it from happening is relatively easier and simpler. Just manage blood pressure, manage the risk factors, manage blood sugar and all these few other things. That is a lot cheaper and a lot easier compared to dealing with the stroke itself once it has happened.
26 million stroke survivors globally, Mr. Nyambega. Coming closer home to Kenya, what are the issues stroke survivors are dealing with?
Actually, that number is huge. And getting back now in our country, it's even more. Because as of now, we have not had exactly the number of people with a stroke. But when you look at things the way they are, the number is huge. Because basically, if we had these figures from each hospital and even health centers or all this, and then we could really know, we could vaguely know the number. But I think very soon we're in a position to do some mapping so that we know exactly where we stand. Otherwise, it's a bit hard to tell exactly. But the government is now ready to help us, because we have been to Minister of Health. They have promised that they will help us to do this. And I think that is the point. Yeah.
And it triggers my mind towards, the Stroke Association of Kenya. I'm very sure you have members that deal with this condition on a day-to-day basis. What exactly do they lack, or what can be done either by society, family, government, people in the medical profession to improve the quality of their lives?
Actually, the problems of survivors are many. You cannot tell, because that's why actually we decided to come together, so that now we do things together, and find out from you how have you done, what are the challenges that you have, so that at the end of the day, when you go to the government, it's to tell them we need this and this. Yes.
What is the hardest part of your recovery 8 years down the line?
Really, medically, yes, I think I'm now stable, because the medicine that I'm taking are quite okay. I'm not, when you keep on changing the regime of drug, I have never changed. Whatever I was putting is still helping me. So really, what my hardest thing now is rehab. Rehab now, that's why I don't want to leave people like Kembwe.
Yes.
So that now we just push together. And the people like Dr. Andege, I go there maybe after 3-4 months for checkup.
For checkup.
Yeah. And anytime that I have any major problem, I can go. They assist. So really, this is a process that we need to keep in touch. Yes.
Maybe I could add on to that a little bit.
Yes.
Because at the end of the day, stroke tends to end up leaving people with an element of disability.
Yeah.
You cannot move around as independently as you would.
Yeah, of course.
You cannot express yourself as clearly as you could before. Now, one of the major challenges which people face in our country is because our thinking and planning for people who are not independent in mobility is not very good. So you find that if you try to go from here to Upper Hill or to Westlands and you have got an element of disability, you can't walk very well, you are going to have a lot of trouble. You're going to have trouble because there are no ramps for you to walk along slowly. The pavements are all irregular. You find you are stumbling and you're falling down. You can't, they are trying to climb into the bus, into the matatu, for example, the stairs are narrow and small, so you really can't go up very well. The toilets, we don't have too many disability toilets where you can go and say that a person, because when you want to go to the toilet, you want to go there alone. You don't want to be assisted by too many people there.
Yes.
So there's a design how you can go in and be able to help yourself in there. Most places don't have that kind of facility. So it's really challenging. So that's why people of influence like yourself, Sam, can come in and be sensitized about these things so that you can pass the message to the policymakers, to the governors, to the counties, that people who have an element of disability, people who are not able to move around independently, as well need assistance so that they make regulations that buildings must have ramps for people who are using wheelchairs. There must be a lift if you cannot go up on the stairs. Public service must be made in a way that you can be able to move in and enter without a lot of stress. Surveys in counters, if you are going to buy something, they need to be made in a way that you can be able to reach there. People need to be sensitized, even information that some people have got trouble even with speech. So that if I come to you, you are selling something in the shop, and I'm trying to say something and you don't hear very well what I'm saying, you don't understand what I'm saying, you have patience and listen carefully to understand how you can help me. So that is a matter of policy. It goes beyond the medical profession. It goes now into the arena of policy and political leaders. How do we sensitize them to take these issues of disability into account when they're making their programs?
Rehabilitation. Kembwe. Evans did point out that right now he's dealing with it. He's managing it one step at a time. And you'll be asked to have a lot of patience. This is both for the family and for the patient. But patience could wear off over time. At times when they come to you, To empower them, you tell them it's all in the brain. You can do this. However, the brain has been affected, Kemboy. So you cannot rely on it's all in the brain. How do you make the process easier? How do you make sure that you're able to balance both the expectations and feelings of the patient and family or whoever is taking them through therapy to ensure that you get maximum result from the rehabilitation?
As you talk of rehabilitation, one thing that we consider most is, after talking with the family, that is guaranteed that this patient will come up having a very positive mind. The acceptance level of a stroke patient is very high. Because in an instance whereby you find that that patient doesn't accept the situation, it's going to slow recovery. Because you find this patient is depressed. Because the patient is saying that he's no longer able to do all the things that he was used to do before, of which that is a challenge. So once you have talked to the patient, you have talked to the family, and the family has accepted that they are going to support the patient. So you'll find the patient that is very positive, because before we discharge a patient, we go to the family, we talk to the family. Before talking with the family also, we have to assess the environment within the home setting. We make sure that we do some modification to ensure that this patient is able to live a very comfortable life despite the challenges that the patient has. For example, if the home settings, for example, the patient, the family is living in maybe a house with a lot of stairs, we really recommend that that patient to be taken ground floor for easy transfers. Another thing, we look at the toilet. How is the toilet? We ensure that we modify it to ensure that we've got some handrails, whereby this patient, when he goes to the toilet, is able to do it easier. Another thing is, at least we also go to where the patient sleeps. You ensure that wherever the patient is sleeping, it's very comfortable, so that we avoid other issues that would rise up to the patient seeing that this environment is uncomfortable. Yeah, that goes into consideration with the doctor's recommendation, whereby he say that stroke is a disability, whereby you see a patient moving around is a challenge. Yeah.
Psychological empowerment.
Yeah.
It's not easy, Kemboy. I was walking an hour ago. Now I'm struggling.
Yeah, that is it.
I had a good life minutes ago. Now I'm struggling.
Yeah.
And as Daktari said, it's a stroke. A majority of the times, it just strikes.
That is it.
So psychological empowerment to recover needs to be enhanced a lot.
That is it.
So what needs to be done in that regard, both from family, even in yourself, family, and the patient?
Sometimes on issues to do with psychological empowerment, sometimes you have to seek the services of a psychologist, because the psychologists know better on how to do counseling or to do some therapy to this patient, so that this patient will have a positive mindset. I've heard you the doctor talking about cognition, which for us, first thing we need to do is we do some cognitive retraining, whereby you find a patient is not able to, has issues with judgment, reasoning. Those are issues that we must deal with it first, so that the patient is able to understand all the issues that surround himself or herself.
Or herself.
Yeah.
Yes, sir. Yes.
When you heard on what you said, you will find that mostly when somebody has had a stroke attack, like especially when it is severe, you find that it is not easy for you to suggest anything to this person so that he can understand. That's why you find most of them are very bitter. Some of them are, you cannot understand really what you are saying. That is why now we, as an association, we have partnered with people like mental health care providers, Like there is one that is called Mental Health Plus, so who are working with us, so that these people, especially like when we have we meet every month once, so we call them so that they talk to them on matters they consider this is to do with mental health, so that they are assisted, so that when you say something, now they are with you. Yes, otherwise it becomes very difficult.
Very difficult.
Very difficult.
And Daktari, earlier you said that it is not usual for young people to develop a stroke. However, it may happen, even amongst children. What are the factors that could lead a young person to develop a stroke?
Now, actually, strokes among the young are increasing these days because stroke, to a greater extent, is a lifestyle disease. And, these illnesses we are talking about, like hypertension, diabetes, and so on, these are what people are referring to as lifestyle diseases because many of them increase in prevalence depending on the changes in lifestyle which are happening. So food which is high in salt, sodium, high in salt, food which is high in cholesterol, very little exercise, sedentary lifestyle, sitting at home watching TV or video games all day, a lot of alcohol usage, that kind of thing happens. So notwithstanding that the stroke is a disease of aging, increasingly we are getting younger and younger people getting strokes. I've had patients who are in their 30s develop a stroke. That is because of the changes in lifestyle. And you get that things like hypertension and so on are also becoming more likely in the younger groups and as opposed to before when it was more likely in the older age groups. There are other factors as well, like issues of the blood itself, like say for example issues of sickle cell disease or other conditions where you have got blood which is very likely to clot, and that's what might lead to a stroke even in a child. If a child has got something like sickle cell disease, then they may develop a stroke because the cells will form a clot very easily and block something in the brain. Those ones are not things one can do too much about.
Yeah.
If you have sickle cell disease, then you have to get close follow-up with your provider. However, on the issues of lifestyle, that is now something where a message needs to be put across because young people don't know. You find a lot of young people these days, prevalence rates of smoking are decreasing among older men and so on. But you find the younger women, for example, they still think smoking is cool.
Yeah.
So smoking even this shisha thing, it was banned recently, but I think a lot of women think it's a cool thing to do. And I get a lot of young women who tell me they smoke it regularly. And they don't know that smoking of that kind of thing is also a risk factor. So smoking generally is a risk factor. Use of excessive alcohol is a risk factor. And these are things which are common among the younger members of the population. So these people are at risk of stroke. You find sometimes strokes happen. And you try to look for any other reason, you don't find it. And this person is 20-something. I've got patients who are 28. Then she tells you, I've been smoking. I smoke around 10 or 20 cigarettes every day. So you find that that's the reason why this person has got it.
28 years of age.
Yeah, it can happen at that age as well.
Wow, okay. And there's a term that we've used on this set regularly, and it's what I call debatable relevance. When you say excessive consumption of alcohol, how excess is excess? You know, it's also something we need to define, isn't it?
Yes, absolutely.
So how excess is excess, or to what extent do you consider it excess?
Now, this is something which has actually been documented, so it's not subjective, it's objective. And the figure keeps decreasing as people know more and more about alcohol. The latest recommendations from the West, for example, say that a man should not exceed 14 units, a man and a woman, both of them should not exceed 14 units per week. So 14 units, every drink is a unit. So per week should not exceed 14 units.
14 units.
14 units.
So drink measured by milliliters, 300.
Yeah, say a mug of beer
A
or
mug,
a glass
okay.
of wine,
Okay.
or a unit of spirits. So one should not exceed 14. And that's now should not exceed. It doesn't mean 14 is good. It means should not exceed. The levels were higher before. Before they would say men should not take above 21.
I remember 21.
Yeah,
Yes.
and women were thought to, they couldn't accommodate it, so they had to take less. But, and then there's been a study again which came out recently, which says that any amount of alcohol, any amount, before, people thought that taking some small amount of alcohol is good for your heart, it protects you from various things and so on and so on. Now this is still controversial because there are still some people who think that red wine, for example, has got some antioxidants or other things which are good for health. But this study which was done recently followed up a large amount of people over several years. And they found that the harm from alcohol, the development of dementia, development of cancers, development of hypertension, strokes, all kinds of things. They said no alcohol is safe. But the higher you take, the worse it is for you. But I think if one really needs a guideline, one should try to follow this one of 14 units.
14 units.
And not all at once.
Or better yet, just stay away from it.
Better stay away from it. And when you say 14 units, some people think you take them all at once. So they say, I'll take my 14 units on Saturday. So it's not that way at all. It's cumulatively, in the course of the week, don't exceed that amount. Yeah.
Gentlemen, we've got to bring this conversation to a close. So it's time for final words. And I'd like to begin with you, Kemboy. What message would you like to leave our viewers with in as far as rehabilitation and occupational therapy for stroke is concerned?
I would like to tell them that stroke, there's life after stroke. And it means with rehabilitation, a person can be brought to a functional capacity. For, saying functional capacity means that we as occupational therapists also, we can do job resettlement, we can do driving if a person have challenges in driving after stroke.
Okay.
So I say that this life after stroke and the independence level of stroke improves.
Improves with time. There's life after stroke. Over to you, Evans.
Actually, I could like to say a few things. Like, one, this is doing with the international assignment in making everything bubble. Yeah, because this is Awareness Month.
Yes.
Yeah, globally.
Yes.
Meaning that you go to Britain, the headquarter of stroke, you will find the same. You go everywhere the same. So I think it's going to start with you on our behalf. Yeah, so that now I think I can give you a few brochures so that you can tell the world that stroke must come to an end. Two, we this month, because we saw that it is important that these people called survivors and caregivers require some kind of training so that they can be relevant in future.
In the future.
So we want to call them for a workshop, a 2-day workshop, which will be held this month, end of this month, so that now we train them each with a role to play, so that they don't, sometimes it's very difficult. A caregiver and a survivor, they keep on, having, what we call so we don't want these kind of arguments. We want each to understand the role that one plays.
Okay.
And I think
that's it.
That is it.
Thank you so much. Over to you, Dr.
Thank you so much, Sam. Now, my message is simple. Stroke is a preventable condition. A lot more effort needs to be put towards preventing stroke as opposed to managing the effects of stroke once the stroke has occurred. So for the policy leaders, for the leaders in government, for other people who may be watching who have got a way they can influence the direction stroke will take, there's a lot of interest and there's mileage If you say we have built a brand new large hospital with MRIs and everything to treat stroke, but this is just treating the people who have already gone through the whole pathway of developing stroke. That is good, but what is even better is putting into place community level interventions to prevent these lifestyle diseases, because stroke also comes along with other vascular diseases like heart conditions and so on. So the most important message that one can have is that let us also treat the underlying conditions, let us manage the community level. So let us manage hypertension, let us sensitize people on diabetes, let us change people's lifestyles, let empower them to change their own lifestyles, encourage people to exercise more. When you're planning a city, make sure you put playgrounds and other places where people can go for recreation, because those are things which help in prevention of the lifestyle diseases we are talking about. So stroke is a preventable condition, and the leaders out there need to get out and sensitize their people on the things which can be done to prevent strokes from happening, because a stroke is devastating.
Sure.
Better prevent than cure it.
That's very true.
Last
And,
but not least,
Okay, very quickly.
I was forgetting.
Yes.
Stroke Association is alive and it's working. Actually, we are on what you call Gong Road, just behind City Mortuary. Anybody with a challenge of stroke may come and,
Access
and
you.
we can assist.
Yes.
Yes.
Thank you so much.
Thank you.
Thank you so much, gentlemen, for coming. Dr. Ndege, Oscar Kemboi, and Evans Nyambega, thank you for coming, for sharing the story, your story, and your insight in as far as this issue is concerned. And thank you for watching. We do hope that at the end of the day, you have your take home.